All right, thank you for joining us for today's event on epidural steroid injections and medical review findings. My name is Mary Sue Gardner, and I'm a registered nurse on the Provider Outreach and Education team. And I'm going to be your facilitator for today's event. And I'm also joined today by other members of Provider Outreach and Education, as well as medical review, who will be helping with the chat portion of today's Q&A if we need them. Just a few little housekeeping items of interest. Before we get started, as I mentioned briefly, we will be posting this as an encore. It will be available on our encore page on WPSGHA.com, and that'll be available for 60 to 90 days on that encore page for you to view that video through YouTube. So it's a built-in YouTube player, but it's always available on our YouTube page until we do an updated training event or if CMS happens to change their regulations. So do become familiar with the Training Web Center page. This is where you get your training materials, where you register for events, anything like that that you would need. If you have comments or questions for today's event, please put those questions in the chat and send those questions to all panelists. And then after this event, you will have the opportunity to take a survey on the event and tell CMS how we did, what you liked, what you didn't like, and what information that you need in the future. So suggestions for future educational events. This is just our disclaimer we have to show at every presentation, and the disclaimer basically says, the information I'm giving you today is as true and accurate as it is today, but know that Medicare laws, rules, and regulations often change. So it's your responsibility as someone who is providing services to a Medicare beneficiary to make sure you are following the most current laws, rules, and regulations that are in place on that date of service. So refer to CMS Internet-only manuals because CMS has final coverage determination. And then acronyms, Medicare's full acronyms. So if I happen to use an acronym today that you're not familiar with, go ahead and refer back to this list. If I refer to an acronym and it's not on this list and you don't know what it is, but you want to know what it is, just put that in the chat and one of my associates can help get that answer for you. All right, that brings us to my objective for today's event. And my objective is that you gain some clarity on our expectations of what needs to be contained in your epidural steroid injections documentation, so you can avoid findings if you're ever selected for claim review. We're going to accomplish this today by reviewing Medicare coverage criteria for the ESI or the epidural steroid injection, outline the required documentation to support the medical necessity, and we're going to also discuss some key medical review findings and some of those common errors. So let's get things started off by talking about the coverage criteria. But before we dive deep into that coverage criteria, let's talk a little bit of history on back pain that we actually have this information listed in our LCD. So low back pain is highly prevalent, with reports of 50 to 84% of adults experiencing back pain at some point in their life. And there's a high prevalence in adults that are 65 and older, and it causes disability globally. So low back pain and neck pain can influence a person's quality of life and their functioning, and it's associated with depression and anxiety. In 2018, the National Health Interview Survey from the CDC reported that 28% of men and 31.6% of women that were over the age of 18 had lower back pain in the last 3 months. So there's still debate and a lack of consensus on which modalities are best to treat chronic lower back pain. But we wanted to give a little bit of that history here before we start about one treatment option. So epidural steroid injections, or ESIs, for back pain. An epidural steroid injection, those are non-surgical modalities to treat lower back pain and neck pain. So these procedures typically involve the injection of a solution that contains like corticosteroids and or anesthetic into the epidural space, and saline sometimes can be included. Currently, there are no FDA-approved biological agents for the use of spinal injectants into the epidural space. So for this reason, if you include a biological or other agent other than corticosteroids and saline and, that anesthetic solution, your claim could be denied. So we have a local coverage determination for epidural steroid injections, and that is actually linked here. So if you have the slide deck available, you can click on that and it'll take you straight to our local coverage determination. So in these next couple slides, I've broken up the components of our LCD. Again, this link will take you right to that. And I want to talk about these indications. So starting with the first indication of coverage, the service must be medically reasonable and necessary. So what does that mean? That means that on this day of service, this person needs the service, this specific ESI, and that it's the most safe and effective treatment for that patient's current condition on that date of service. So they must need you, your clinical expertise, to assess the condition, to treat it appropriately. So where in your documentation are we going to turn to look for medical necessity? There could be several places. Most likely, your physician H&P, any imaging that has been performed to support the need. We're going to look at any other supporting documentation, progress notes, etc., for those assessments. We're going to look for those indications of pain that are impacting that patient's quality of life. And finally, does your documentation contain evidence that this pain has been persistent for at least the last 4 weeks? So I'm going to break this medical necessity of this first component down a little bit. I said we are going to start looking at the H&P and the imaging to support the need. In that, we need to see one of the following things that's listed here on the slide. And I want you to pay close attention to the and or statements that are on here. So if a statement is followed by an and, it must contain both or all of those elements. Or if there is an or, you must support one or the other. So the ESI will be considered medically reasonable and necessary when the following 3 requirements are met. And let's go through those. So history and physical exam, and the radiological imaging, and any kind of diagnostic testing that supports one of the following. So one of the following needs to be met: the lumbar cervical or thoracic radiculopathy or radicular pain and or neurogenic or claudication due to disc herniation or osteophytes or osteophyte complexes, or severe degenerative disc disease, etc. Or then we go down to post-laminectomy syndrome or acute herpes simplex zoster associated pain. So one of these, and as we move on, the radiculopathy or radicular pain and or neurogenic claudication is severe enough to greatly impact the quality of life or function. So there's got to be an objective pain scale or a functional assessment performed. And that's got to be done at baseline, so prior to your intervention. The same scale must be repeated at each follow-up assessment and the response to that. And continuing on with that medical necessity component, that pain duration, you have to have it documented for at least 4 weeks. I mean, you have to have documentation that is persistent for at least 4 weeks, is what I mean by that. And the inability to tolerate non-invasive conservative care or medical documentation that a conservative care has failed, that failed to respond in that 4 weeks. So, or you have that option, remember, of if there's acute herpes simplex zoster, and that's refractory to conservative care management, where that 4-week wait is not necessary. So again, we go back to the medical necessity and how do you meet it? And here's how you meet it. You go through and you make sure that these things that are listed as and ors are contained within your documentation. If it's not, we can't in good faith give you Medicare money for something that is not documented as meeting the medical necessity criteria. So as we move on with the next covered indication, so an ESI must be performed under a CT or fluoroscopy image. And it's got to be done with contrast, unless the patient has a documented contrast allergy or pregnancy. So in that case, ultrasound guidance, may be considered. But remember, if you don't document the allergy or the pregnancy or whatever the contraindication is, we will not know if it exists. And your claim could be subject to denial for not documenting the use of the contrast media. Covered indication 3, the transforaminal epidural steroid injection, or TFESI, involving a maximum of 2 levels in one spinal region, are considered medically reasonable and necessary. So it is important to recognize that most conditions would not ordinarily require ESIs at 2 levels in one spinal region. Here again, this is where your documentation needs to shine, so you must support the reasoning in order for us to consider it for coverage. Covered indication 4. So caudal epidural steroid injections, or CESIs, and the interlaminar epidural steroid injections, or the ILESIs. And those involving a maximum of 1 level are considered medically reasonable and necessary. So while they're both used to treat back pain, they differ in their location and target area. So make sure you are supporting your type and level you are injecting at within your documentation. Covered indication 5. So it's medically reasonable and necessary to perform the TFESIs bilaterally only when clinically indicated, such as when a patient has pain or radiculopathy that affects both sides of the lower body. And that's sometimes due to conditions like bilateral foraminal stenosis or a degenerative disc disease. So in those cases, again, make sure your documentation supports that. Covered indication 6, repeating the ESIs. When the first injection directly and significantly provided improvement of the condition being treated, it may be reasonable and necessary when the medical records show that there's been at least 50% of sustained improvement of pain relief or improvement in function which again is measured at baseline, and you use the same scale to measure it for at least 3 months of time. So if a patient actually fails to respond well to the initial ESI and you're choosing to do a repeat ESI after 14 days, it can be performed, but it needs to be performed using a different approach, which is like a different level or a different medication or amount of medications, etc., with the rationale and medical necessity for the second ESI documented in the medical record. So again, if your first one works and you need to proceed with another one, you have to wait at least 3 months. And there's got to be documented sustained improvement. If it didn't work and you want to perform another one after 2 weeks, that can be done, but you need to tell us what's different. If we don't have that information, we can't in good faith pay you because it goes against the covered indication. All right, so covered indication 7. An initial injection of contrast is required to confirm that epidural space placement. So really, unless that patient has a contraindication to contrast, the contrast should be used, and it should be documented, and it should contain the amounts, etc. Subsequent epidural injections should include corticosteroids, and also combined with anesthetics and saline as well. So again, we're going to need to see that documented, and it all comes down to your documentation to support it. So we have several coverage indications here, 9 coverage, and we're on 8 at this time. But the point being is, make sure you are looking at these covered indications in the LCD and that they are reflected in your documentation. Now, that may mean you have to get additional documentation from other places. If we are asking for documentation from the hospital to support these covered indications, you may have to get information from the physician's office. All right. So covered indication 8. ESI should be performed in conjunction with conservative treatment. Now, I've touched base on this a little bit, but these conservative treatments could include things like physical therapy, over-the-counter or prescription medications like NSAIDs or maybe an antispasmodic, rest, posture correction, even chiropractic care for a manual manipulation to correct a subluxation. There we go. And then finally, patients should be part of an active rehabilitation program. So a home exercise program or a functional restoration program. Remember, for every indication, there's also limitations listed in our LCD. And these are the reasons that could cause your claim review to be unfavorable. They include things like not using image guidance or contrast media, and no indication of why. Biologicals that were used that are not FDA approved. Performing multiple types of blocks at the same time, like an ESI and a facet or a trigger point. So basically, the opposite of the indications that we just went over are also the limitations. But if you perform these services, I do encourage you to use that link and go out to the LCD and read over those indications and limitations. All right. So we discussed what indications are covered and how the opposites of those things are also included in your limitations. Let's move on to how we support that in your overall documentation. There's several components of documentation that we ask you to submit if we're performing a review of ESI services for you. most of these are pretty straightforward based on the fact that we just talked about all these things in the coverage criteria. So we'll break this down just a little more. We always ask for a history and physical. This is generally where we're going to see that background information about the patient, about their pain, about the history of treatment, medications, physical findings. So physicians, this is your time to shine and really show us why the patient needs this procedure. Or if you are doing an H&P and then referring the patient to another physician to perform the service, again, it's your time to shine and give us all the information about what has been tried, how long you have been seeing this patient with this condition, how long the patient complained of things, complained of the pain, either neck or back. Not only do we look for this in your H&P, but we also look in your progress notes and past office visits. So it is usually in the notes that we're going to be able to see that the pain has been present for at least 4 weeks. And if there's any inability to tolerate non-invasive or conservative care, the medical documentation needs to support that. Or if there's been a failure in that conservative care, or if they have acute herpes zoster, then that would be, which negated the 4-week wait, that would need to be present as well. Imaging. Any imaging performed should be in your documentation. This includes any interpretation of the findings. So sometimes if a radiologist reads an image and the physician that's performing the ESI has a different interpretation of that image, then your physicians need to document what their interpretation of the actual imaging is to support the diagnosis and the recommendation for that treatment. Prior conservative treatment. So again, I've already mentioned this, what was tried, what was failed, was there any relief, how much relief, etc. The use of CT or fluoroscopy imaging with contrast needs to be documented. What contrast was used, how much was used, what imaging was used. Additionally, procedure reports, including the injection and the amount, any prior procedure reports to support your frequency. Remember at the beginning I said part of the covered indications was some frequency limitations and when they can be done. So if you are providing services outside of those frequency limitations and your documentation doesn't support that, we can't again pay you for that. Objective pain scale or functional assessment. The important thing is make sure you are documenting using that same pain scale and or functional assessment at every visit. So before you do procedures, after you do procedures, etc., on subsequent clinic visits, use the same scales so you have consistent data for your patient. And then again, any positive clinical responses the patient has, how they did after, how when things continued to go bad again, we would want to know that. And finally, signature attestation, if it's applicable, and ADN. So we always need to see signatures within your documentation, even if it's electronically signed. If there is a need for signature attestation, that would need to be included. And if you happen to issue an advanced beneficiary notice of non-coverage because you had reason to believe that Medicare may not pay that specific patient or that specific procedure for that patient for that day, then you would issue an ADN and you would supply that to us within the documentation. All right, which is going to lead us into review findings. So let's transition into what our medical review staff is currently seeing. Listed on this slide are the top most common reasons for denial on medical review. And we're going to break these down in the next upcoming slide. So missing doc, failed prior injections, timeline requirements not met, failed conservative treatment, and incorrect billing. So let's start with missing doc. That can include any component that we just talked about being missing or not in the record. But most often, it includes the pre and post injection pain assessments. Remember, it's important that you're measuring this using the same scale each time. So the next most commonly missed piece of documentation or not provided to us piece of documentation includes the imaging to support the diagnosis. So what imaging was used to say, yes, they have this pain and this epidural would be of value? Was there MRI? Was there CT scans? Are there flat plates? Is there any imaging that was performed prior to support this diagnosis? If it is, we need to have those interpretations as well. So this imaging, again, needs to contain the interpretations. And again, remember, if the physician performing the service reads the imaging themselves and has a different interpretation than what's on the radiologist report, then that report needs to be separate from the radiologist report. And then under missing documentation is information to support why you are repeating the ESI. Remember the indications we talked about with repeats. So repeats can be reasonable and necessary when the first injection had significant impact for that patient, and the medical records show at least 50% of sustained improvement or pain relief and improvements in functioning. So this, again, needs to be measured using that same scale for at least 3 months. And then there's the other exception. If the patient fails to respond well to that initial and you want to do a repeat after 14 days, you can do that, but you have to document that different approach is being taken. Data documentation is important to show how long it has been between those, because we are going to use those dates to make sure that you meet those timeline limitations that are noted in the LCD. All right. So as we move forward, there we go. So as I mentioned with the repeat performed at 14 days because the injection failed to respond well, we must see that there was some sort of change in approach. Sometimes the approach change is a different level or a different medication or a different amount of medication. So when we don't see any kind of changes to the approach, to the level, to the medication, then, and we see that it's being done, you know, before that 3 months and maybe after that 14 days, it's not going to meet the coverage indications because we're not going to see that there was something else being done and the reason for the fail. Timeline requirements, and I've been beating this dead horse all along. So these are all coming together as one now as we talk about these most common issues. So if your ESI worked and your patient got the desired effects, again, 50% of improvement, you can repeat it after 3 full months, okay? If they did not, you can repeat after 14 days, but you have to support that different approach, the different level, different medications. Next is failed conservative treatment. So back during the indications section, we talked about the fact that you need to document what conservative treatments have been tried and failed prior to just going to the ESI. So you must document the pain history. We must see that it has been at least 4 weeks of this pain history. During that time, what has been tried? Again, medications, physical therapy, chiropractic care, etc. What tried and what worked, what didn't work, what provided some pain relief but not significant, what just didn't work at all. So those are some of the things that we are going to specifically look for. Remember, those indications may also come with expectations or come with exceptions, to the rule. So if they need to repeat something sooner than the LCD says you can, then you need to support the why for those, for us to even remotely consider that. Do they have a condition that warrants not meeting the LCD? So such as the acute herpes zoster refractory to conservative management, where 4-week wait is not required. So if that's the case, just make sure it's documented and make sure that that diagnosis is included on your bill. And then part of the duties of medical review is to make sure you are meeting the coverage indications and medical necessity, and also check those medical indications, that medical necessity documentation against what you bill. So your documentation and your bill to Medicare must match. If it's on the bill and we can't find it in your documentation, we can't pay you. So the drugs and contrast material must match. Most often, we see the reported amounts not matching what's billed. So in this case, we can sometimes downcode to pay at the amount that we did see but was provided. But we don't have to do that. We can deny the drug because it wasn't provided as billed. If the drug is required, we can't pay that service. So they go hand in hand. So it's important to make sure that you are billing the services and the drugs used appropriately. Remember, if a drug requires you to report waste, make sure you're documenting and reporting that appropriately as well. And that may not necessarily be part of a problem for the ESI services, but just remember, it's just a reminder for your practice, because some drugs do require you to report the waste as well. So again, remember that your J codes and your Q codes need to be billed need to be documented and billed the same. All right. And then finally, ESIs are not part of prior authorization. So don't waste your time. Don't waste our time by submitting them. We see that they are often confused with the outpatient hospital facet joint injections that are on the prior authorization list. These are different. They don't require prior authorization at this time. Now, that doesn't mean that eventually CMS won't change their mind and include these, but for right now, ESIs performed in the hospital outpatient department are not part of the prior authorization request. And you can check the code list for the ESI in the local coverage article versus the code list in the HOPD prior authorization list that's on our website. So this is the easiest place to make sure your billers and coders are aware to check that code against if it is a required part of the prior authorization request program or not. In this case, the ESIs generally are not part of that. And like I said, but don't be surprised if somewhere down the road, CMS does decide to include them in their prior authorization request. Okay, So that takes me to resources. There's a plethora of resources. I've given you a link to the LCD a couple of times. Within the LCD, you can also link to the local coverage article, but you could also use the links that I provided here. We've got some information on our medical review section of our website about the epidural spinal injection reviews that are going on. So I do encourage you to take a look at that. And then we have another article here on the WPS site about anesthesia for pain management procedures. So before I look at the questions, I'm going to recap. What did we do today? So by going over all of this, we've achieved my objective for today's event. We gained some clarity on Medicare's expectation. I'm going to help you strengthen your documentation practices. I want you guys to all take back the information and make sure your documentation is matching what those covered indications say you must have within your practice to support your services as reasonable and necessary. And we learned what those common errors are, and by learning what they are, we've learned how to avoid them during a medical review. So let me look over at the chat, because I did see a couple of questions come in, and I want to make sure we address those. So if a patient has received epidurals with consistent relief and then has one injection that didn't last the full 3 months, can the patient have another one, or are they not able to have any more since it wasn't their first injection? So yes, they have to wait the 3 months in this case to have another injection. And then again, we're going to look for that documentation that, was providing pain relief, et cetera, on a consistent basis until it no longer was. But the way the coverage criteria are, it's got to be that 3 months. And then for home exercise program, does the provider need to advise of the exact home exercise information, such as leg extensions 4 times a day, et cetera? If you, the provider is giving the patient a list of exercises that you want them to perform, then make sure that's documented. We gave them fact sheets on leg raises, whatever exercises those may be. If the home exercise program was developed by physical therapy, you can simply note that the patient has been continuing their home exercise program, as advised by physical therapy, blah, blah, blah. If you know what any of those exercises are, document it, but if you don't, you don't. But it is advisable if you are providing them a list of exercises, just make note of what sheets, what exercises you gave for them to follow. It just goes a long way to prove that you, as a provider or provider's office, are doing the things that you need to do in order for your patient to get better. Okay, and not seeing any other questions, I'm gonna just quickly pull in a little bit of documentation. We have just a few minutes, but I think this will really help you as providers see some of the issues that we see. Now, this is documentation of a patient that for ESI procedures, and this procedure was done on 3/24/25. Okay, so we have the information, have it as an operative report, we have pre and post pain assessments, we have the level, the fluoroscopy information, we have the information about what needles were used, what injectants were used, et cetera. That's all documented here. So we have the information pretty much that we need for that day of service. But I'm going to scroll back up. So that was, again, 3/24/25. So as I scroll back up to the top, and I kind of just jumped around with some information here, On 5/12/25, I find a history and physical report. So 2 months later, and there's an H&P. And we have some information on the H&P, and referred by her primary care for cervical pain, but then the patient states her cervical pain is now gone, and she's requesting treatment of the lower back. But the information from March was for lower back. It was lumbar L5S1. She does not have any imaging at this time for her lower back. It sounds like she needs imaging. Her pain does decrease her mobility. She tried some conservative therapies for her back that aren't working, but we don't have any indication of what those things were. And then the rest of this is just kind of a review of system and a general history and physical. And so the procedure is going to be L4, L5, epidural steroid injection is what they were thinking. Okay, and it goes on. I know I'm going through this quick, but I'm scrolling back through. This is the March stuff, L5S1. And scrolling quickly, so avert your eyes if you have a seizure disorder, L5S1. And then we get back here to the May information. So we have a provider progress note where they're saying return to the outpatient from their primary for L5S1 now. Same date, 5/12, as the H&P I was showing you. And that H&P was actually performed by the CRNA. And then this is the progress report saying the epidural steroid injection went as planned for L5S1. And then we have a little bit of information here. Their relief, L5S1. Again, it was in May. And then we have all that information about the procedure itself, et cetera. So we have conflicting documentation of what levels from the history and physical to the actual procedure, which is fine because, you know, when sometimes if it was one provider and they thought it would be at one level and the actual performing provider says it's at a different level, okay. But we don't have any other indication as to why March was done, and then they redid it again 2 months later at the same level, same amount of injections, et cetera. So nothing to support doing that more frequently than it was done before. And I know that is quick. And I do see one other question, how recent should imaging be? I do see two questions. Recent imaging is imaging within the last year, or if there has been any other issues to your patients between the last imaging and the planned procedure, like if they've had a fall or some other unexpected change, then imaging should probably be repeated. How recent should the physical therapy be? There are some commercial plans that require at least 6 weeks within a 12-month period. Medicare doesn't have that indication for this service. We just need to know that this person has had some other service, some other form of conservative treatment prior to this service being done. If physical therapy is being done, we would want to see that physical therapy was tried and true. Now, just to say the person went to physical therapy once, it's not really tried and failed because the person didn't continue with that. Your physical therapists are going to be the best ones to know how long it's going to take them to evaluate and treat that patient for that illness or injury, you know, at that time. So while we don't say 6 weeks, 6 weeks is not unheard of amount. All right, and I think I didn't miss anything. Jennifer, were there any other questions that I missed? I want to, in the interest of time, keep on moving.
No, that's all the questions in the chat.
Perfect. All right. I want to, I know we're right at call end time, so I want to thank you for sticking with me for these last couple of minutes. All right. In a little bit, you're going to get a certificate of achievement in the form of an email. Should be in your mailbox right now. If you only called in, you are going to have to email me at that email address that is in the chat at wps.gha.education@wpsic.com. And so check your spam junk folder, make sure your certificate didn't land there. And if you didn't get it because maybe you logged in via a mobile device, just let me know and I can send that out to you. It also has the ability to provide feedback, take the survey within that response. It's just one other additional option. If you have any follow-up questions, if you think of them, after we get done, go ahead and send those to me at that same email address. It's listed here. And if you have the slide deck, you can even click on this and it'll populate your email for me and send it within the next 7 days. And then just, whatever the question may be, if it's relevant to everyone, I'll send out the answer to everyone. If it's claim specific, however, those have to go to customer service because I don't have access to the claim system to look up your claim. And physical therapy 5 years prior still counts. If the physical therapy is that long ago, I'm going to say no. Your physical therapy needs to be recent within that illness period of time before the epidural steroid injection is done. All right, surveys. Jennifer's going to place a link to the survey in the chat, and once the webinar closes, a site's going to pop up that looks like this. It is not spam, it's just WebEx's way of routing you to our survey. So it is not spam or junk, and you can go ahead and take it from there. We value your opinion. We want to know, but most of all, take the survey in its entirety because it's your availability to tell us what other type of education that you need or want in the future. So we take those opinions seriously, and these are some of the changes that we've made from that. So we added chapters to our YouTube, so you can click through a YouTube now and go to the sections that you want to listen to. We've also included some training indicators in our advertisements. So again, thank you for those of you who were able to stick with me for these additional couple of minutes. On behalf of Jennifer and myself, as well as our medical review department, we want to thank you for your participation in today's event. So this concludes our webinar, and you may now disconnect.